Dr. Anand Krishnan, our chairperson for the day, for the session. Co-chair Dr. Sushmita Shah. I welcome Dr. Anita Venugopal, co-convener. Yes, thank you so much. And he will be talking on cataract surgery and corneal disease, restoring the sight.
I was under the impression I'm the second speaker, sorry, that's why I kept it open.
Dr. PVK will be with us in a short while.
I understand. No, you can cut it directly.
Dr. John.
So, thank you so much once again for having me over here. And the topic given to me is cataract surgery in corneal disease. And since almost everyone in the audience is either a speaker or a moderator, and all of you are experienced surgeons, I think I'll just share a few points, few views which I have on different types of corneal disease and how we manage cataract surgery in concomitant corneal disease, and look forward to hearing from all your inputs. So essentially, I'll take you all through a few of the most common conditions. First and foremost is the challenge with dry eye and dry eye associated disease, irregular astigmatism, Fuchs dystrophy, and hazy and compromised corneas. So with the dry eye, the main problem, apart from treating the dry eye, is also that we are unable to sometimes determine what portion of the dry eye disease is, or the visual loss is caused by the cataract surgery, and what is due to the dry eye disease. And what would be the IOL calculation challenges when we have a patient with a poor ocular surface. Take a look at this patient. Showed a significant astigmatism, but on a closer examination had a lot of punctate erosions in the cornea, started on lubricants and ointments, and then when he came back with a better ocular surface, you could see that there was almost no astigmatism at all. So from a 3.5 diopter to no astigmatism, these can be significant changes in the corneal keratometry readings when a patient has any surface breakdown or punctate erosions. So it's important that we take care of these issues, treat any blepharitis, meibomian gland disease, give them lubricants. If necessary, a short period of soft steroids or cyclosporin would also be helpful, in especially steroids, in restoring the ocular health. And subsequently, even in the post-operative period, it's important that we don't bombard them with too many medications, use a short course of steroids, maybe even withhold NSA drops and give them lubricants. This will ensure that you have a less than stormy perioperative course. In a patient with a more severe disease, sorry, I'm not sure why the video is not running, with a OCP or SGS, you would want to treat the ocular surface first, ensure that you have a very stable ocular surface before you go ahead with any cataract surgery procedure. So this is a patient who presented, actually was referred for cataract surgery with corneal scarring, but actually had a history of SGS and had significant lid margin keratinization. Although it was a total cataract, it was always better to wait to do the lid margin MMG first and then subsequently stabilize the surface and go ahead and do it. In these cases, you may not be able to get away with a routine cataract surgery. Even a speculum insertion might be difficult. You have to use corneal staining techniques. One tip is, wherever there is corneal scarring, try to initiate and complete your excision away from the region of the scar. As a result, you may have some difficulties in visualizing underneath the scar itself. Apart from that, the cataract surgery is pretty routine. All you have to do is probably tilt the globe a little away from the direction of the scar and ensure that you have good chopping techniques, ensure they are all completely separated, the pieces are separated before you go ahead with the phacoemulsification itself. And you can implant an IOL of your choice, definitely no premium IOLs in such situations, and always suture the ports, as the integrity and the tensile strength of the cornea can be compromised in some of these conditions. Moving on quickly to keratoconus, challenge is whether you have centered or decentered cones, whether the patient was a previous RGP user. Again, repeatability of K readings becomes a challenge. So one of the main challenges is we assume there is a fixed ratio between the anterior and posterior cornea in all our calculations, and this can also be altered in keratoconus, and this is another facet which makes biometric calculation for cataract surgery difficult. If you have a little decentered cone, the K readings are not repeatable, you could either do a topo-guided PRK and regularize the cornea, or even do an intracorneal ring segment as in this particular case, and then improve the cornea. So you need to remember that the keratometry readings have to be stable, not just in terms of magnitude, but also in terms of direction if you have to choose a toric IOL. In case the direction of the K readings is not repeatable, for some reason the video is not running, I'm sorry, it's not repeatable, you would do well to just go ahead and put in a spherical IOL implant and then continue the patient on a contact lens, either a RGP or a Rose-K. If you put in a toric IOL and the patient requires a contact lens later, it will actually end up uncovering the astigmatism corrected by the toric IOL, and the patient would require a significant power on the glasses as well. Again, aim for a slightly myopic outcome, and in case in some of these extreme cases, you may even have to resort to using a piggyback IOL if the residual power is significant. PMD, again, less of a concern. You can use customized toric lenses, which are quite useful. Post PK and DALT, yes, to the extent possible, we can ensure complete suture removal, but more than that, it's repeatable topography and K readings, which are very important. Again, in this video, as you would notice, there are some sutures left in, and they have been left inside for almost a year now, and the K readings and topography have been stable. The astigmatism is less than 3 diopters. So it's not a mandatory requirement that all sutures have to be removed and the patient has a significant posterior subcapsular cataract. Also, the astigmatism can be quite high in some of these patients, and you can use even customized toric lenses. There are these Ultima Smart toric lenses available from Care Group, which are quite good, and you can correct very high degrees of astigmatism and odd powers even with these IOLs. With Fuchs dystrophy, again, you may have to combine with a DSEC or a DMEC. With DSEC, it alters the posterior curvature, so you would have to add a 1.25, 1.5 diopter to the power. With DMEC, of course, the impact is quite minimal, and you can go ahead with the same surgery. Again, early Fuchs dystrophy, you may have slight epithelial widowing, which may alter the K readings and make the repeatability of the K readings quite poor. I think because of paucity of time, I will not go through the details, but with other end of the spectrum where you have grafts which are failed grafts with poor quality of vision, you can use alternate illumination, either retroillumination techniques. You can use chandelier illumination as used in this case. These are just visualization techniques with hazy corneas to improve outcomes. It's just important because you can do a safe in the bag phacoemulsification in these cases, and when you combine it with an endothelial keratoplasty, you would want to have a stable IOL in the bag so that during all your air bubble maneuvers, the IOL does not get displaced, and you can go ahead with a safe surgery. Again, it's also important to realize when not to do a combined surgery. Now, this is a one-eyed patient with a neurotrophic cornea who had a secondary bacterial infection and had healed. So in these cases, even though the corneal scarring is quite significant, the patient also has a dense brown cataract. It's just important that we ensure that we can give the patient sufficient quality of vision for a long period of time and not combine a corneal graft in these procedures. It's just one point with regard to cataract surgery to emphasize is that ensure that the pieces are completely separated and chopped right up to the posterior plate before removing these pieces. Because if we try to maneuver and remove them with poor visibility, if there is inadvertent zonular dialysis, then the whole situation becomes a lot more difficult and tricky to manage. So ensure that chops are complete and multiple chops are being done, and then subsequent removal and surgery is quite easy. Thank you so much.
Thank you so much, Dr. Shreyas, for sharing your cases, all challenging ones. I would also like you to answer this question. In which cases would you like to do an SICS? Would that be a choice?
Yeah, even in the last video which I was showing, an SICS would have been a perfectly acceptable option. It's just any surgical technique that we are comfortable with for that particular case. The only places where I would possibly avoid an SICS is where I don't want conjunctival handling or scleral handling, like in OCP and other conditions.
Thank you so much.
Can I ask a question? Dr. Shreyas, I just wanted to know your preferred IEL power calculation formula in KC as well as in Fuchs dystrophy. What would you recommend?
In KC
Yes,
and
the
Fuchs
Fuchs
dystrophy.
dystrophy.
Fuchs dystrophy, as such, I don't think there's any specific go-to IOL formula that we have, madam. I mean, it's just the challenge in recording rather than the biometry challenge itself. With keratoconus, of course, Barrett formula has a KC-specific formula now, which can also be utilized. But apart from that, I think it's you can also use, even with the regular calculator, the integrated K values, where you can get K readings from 3 different devices, which helps in bringing down the variability and the errors. If it is a single device, if there is an error, we don't know which one to go to. So you can use the integrated K as an additional vision as well.
Thank you so much, Dr. Shreyas. We now invite Dr. John Sarkar.
So, very good afternoon to all of you. Learning is a constant evolutionary process. That's why we are here, from laying the through sapiens and the sharing of the knowledge is the best way of learning. So, I'll be highlights the management of acute chemical injuries, getting back to the life. I have no financial interest. So, if the patient comes like this condition, already have treated by your fellow colleagues, but it's the time to understand the things. All the patient having the moderate to severe chemical burns, along but all the patient have the visual potential. So you have to, that patient needs the special care. You have to send the patient to your fellow cornea colleagues. So plan a presentation in such a way. So this presentation mainly highlights the appropriate management and outcome by surface reconstruction and recent advances. So prerequisite for the compromised eyes: no surface inflammation, moist eye, correct tear film stability. IOP should be controlled, sound posture segment to be checked by USG scan, appropriate IOL power calculation. When planned for the cataract surgery or approach, the rational surgical plan with minimum tissue handling, and the team approach is always rewarding. And the minimum investigations, so if it is possible, you can check the adaptivity, you can at least predict the integrity of the optic nerve, OCT, anto-7 OCT, to know the depth of the skull or the depth of the panas, thickness of the cornea under the panas. You need to know the anto segment or ciliary body, and USG scan to know the sound posture segment. So I am highlighting the first case was the tenoplasty. This patient come with us. So when you think for this patient not amenable to medical management, with the blanching of the vessels are there, because until and unless you give the vascularization to the limbus, your epithelial defect is not enough. So in this case, I am just first forward the positive time, the first forward the things. We have to remove the vitreous conjunctiva and drag the tendon, and then you can secure it by the fibrin glue, or if you are working in the isolated place, if you don't have a secure glue, you can even also do the notching by semidural vicryls. I am here with the fibrin glue. Along with that, AMT has been placed and surgery has been completed. So you can see the outcome of this patient. It is like this. Ultimately clear cornea combined graph with the no vascularization cornea. I am sharing my second cases. This will come to us for the on and off redness by treated by some government medical college, but clinically we found the CCT panas was there. So what we decided that simply remove the panas, and it is very easy, just like a Rex's plan. Once again the plan, it is by its own. You can do the superficial keratectomy, and cauterization specifically should no until unless there is bleeding. An AMT has been placed. We have taken the prior consent and taking the autoslit from the other eye and its cervical this way, and place it by secure fibrin glue, and surgery and temporary dorsography has been done. So it will give you the initial post-op like this after 14 days once they remove the temporary dorsography, and at the 6th month you can see clear cornea white graph. I think the move on my last cases, third cases. Here actually you can see the patient come with the clustered cornea, almost near total elasticity was there. So we release the sembliferum And in this scenario, we should not be damage the normal healthy cornea. Superficial keratotomy should be done. AMT has been placed. Secured with fibrin glue. I am using the two AMT. One is from the ocular surface, another tarsus. Auto slit has been taken. Placed over there and secured with fibrin glue. This is a kit, so we have done the booster. So these are the immediate post of and post of after 30 days. And we have started the amblyopia therapy and the patient developed the vision 6 by 18. I am sharing my last cases. This patient having a multi-facial injury. So which is initially I have done the tenoplasty salvage line, but it was not subsides. And then I am planning to do the scleral patch cut for this patient. So we have taken the CAG has been harvested from the vertex superior part, same eye. Marking of the devitalized cornea. With the help of the assistance, we make the half thickness of the cornea, otherwise it will hip tough and you will end it up with a dalin and secure with fibrin glue. Additionally, I have given 7 inches Weichler suture to secure it. CAG already I harvested, place it over there, over the AMT, which will act, and then I take up allows that eye having the very extensive damage, so I should not, I didn't touch the other eye, take allow slits, place it over there, and now it's become the reconstructed new ocular surface. Just a couple of seconds. So these are the immediate post-op. You can see this the SPGs in situ, and you can see the after 6 months is clear cornea, white, no single film, and giving the 6/9 vision we need to maintain for last 3 years follow. So what to choose when none will work? Then I think this patient should need the capro, and you should send all your colleagues who will do this. These are the relevant study, and the technical messages are management should be the molecular and the cellular level. We should know which level I am addressing, what I am doing. It should be clear to you. Needs for stage reconstruction should be discussed in details. Tenon advancement in AMD, in the hallmark surgery with the limbal chemical injury, scleral patch graft SVG, the novel approach to address the post-chemical injury acute scleral ischemia, SLATE in acute chemical surgical management can be tried. Understanding of the care group, which where I know and appropriate referral. Dedicated team approach to a patient care in this challenging scenario are very rewarding. Thank you very much. Thanks for your patient hearing. I will take the advantage for on the behalf of OSWB, welcome all of you. AIOC2024. Welcome all of you to the City of Joy for next year AIOC to be held in Kolkata. Thank you very much.
Thank you so much. Any questions for Dr. Tara? Right. So next for
Thank you very much.
so much. So next for the keynote address, I would like to invite none other than our Dr. Praveen Krishna, who needs no introduction. He's the director of Shantilal Chandri Cornea Institute at the L.V. Prasad Eye Institute. He's a meticulous and a brilliant surgeon, and anybody who's seen his surgeries become their instant fans.
Having me speak a little later in the session, and for the keynote, I thought that all of you would have seen plenty of surgical videos of DMEC and DSEC and transplants. So I thought I'll approach it a little differently. I thought I'll speak about talking about how endothelial transplantation really evolved, very little bit about that. What are the current trends in changing trends in transplantation? Where the real challenges for endothelial keratoplasty really lie, and what to look forward to, and if all of us will have a job in about 10 years' time. So quickly, at this point of time, if you look at the evolution of transplantation, endothelial keratoplasty is considered as the pinnacle of corneal transplantation, both from the fact that we don't have any sutures, and also from the fact that the potential visual acuity is as good as you would have surgery. And the different indications for transplantation are actually very varied around the world. And if you consider the indications for corneal transplants in developed countries like in the US, Canada, and UK, you'll see that close to 50% of their indications, at least their top indications like BBK, Fuchs, and failed grafts, are patients who have endothelial disorders. Whereas transplants that are done in developing countries, only about 20% of patients in developing countries are patients who are suitable for endothelial transplants, and most of our other problems are bigger problems like corneal scars and infections. And in fact, the burden of blindness is much more in countries that are developing as compared to developed countries. And the commonest reasons for corneal transplants in India, at least, have very good outcomes for diseases that have good outcomes for following corneal transplants in the West, like PBK, corneal dystrophies, and keratoconus, where you have 1-year survivals in the 80s and the 90s. Whereas you have diseases like corneal scars, regrafts especially, you have abysmal survival rates in our population with 1 in 5 grafts staying clear at the end of 5 years. So now, using this data, we also went and looked at what does the EBAA say from the perspective of endothelial transplants versus regular transplants. Interestingly, the number of transplants in the US seems to be growing every year. Even during COVID, there was a slight fall, but there seems to be a resurgence there. And the most common reasons for corneal transplantation in the US, the blue bars are PK, the red bars are EK, are pseudophakic bullous keratopathy, endothelial dystrophy, which is mainly Fuchs, regrafts, and M is unclassified endothelial disorders. So in fact, the majority of transplants that are done in the US right now are because of endothelial diseases. And also the graph of penetrating keratoplasty and DSEC, which is the blue and the red line respectively, seems to be dropping every passing year, whereas the number of DMECs that are done in the US is actually rising every year. Now, is this something that can be replicated? Is this something that we expect to happen in India as well? If you look at this graph, which is the number of tissues that we sourced in the LVP network, I think there was a brief dip during COVID, but this seems to be increasing as well. And in the network of centers that LVP has, when we reviewed the number of patients who had corneal diseases in the last 35 years, we found that of the 400,000 patients who came in, only a small minuscule number were patients who had endothelial disorders. So in effect, what we see as a trend of increasing number of EKs around the world may not be really applicable to us because we don't see that many patients who have endothelial disorders only. What about the number of keratoplasties? We apparently did about 33,000 keratoplasties in the last 35 years, and these keratoplasties actually are the little pink bits on top, which is actually minuscule compared to the number of corneal surgeries that are done otherwise in an organization. And when we plotted the number of keratoplasties along with the indications, we found that the most common indication for us is still therapeutic transplants, infections, which continues to grow up each passing year. Endothelial keratoplasty seems to be growing, but seems to have reached a bit of a plateau. Regrafts actually have fallen in the last 5 years, so have transplants for corneal scars, dystrophies, as well as corrective. So it seems as if there is a growing trend for transplants for infection, partially for endothelial transplants, but also there's a decline in every other area. Amongst all the transplants that we do, we found that the third most common type of transplants that are done in LVP are for endothelial keratoplasty, and also is the third most common indication for corneal transplantation. And of the 6,000 endothelial transplants that have been done, mainly over the last 10 years or so, we found that endothelial disorders, mainly post-cataract surgery corneal edema, was the #1 reason for endothelial transplants, followed by failed grafts, and then Fuchs dystrophy. We also found some interesting data where the majority of patients, as expected, are patients who were between 40 and 60-year-old age group. And there was a change in the trend where 2/3 of the patient actually were from better financial status as compared to those who had infections, where 2/3 of the patient were from lower socioeconomic status. 75% of these patients had graft for the first time, and there was a significant number who had repeat graft as well. Of the different EK surgeries, DSEC versus DMEC, we also seem to be doing more DMEC in patients who have fuchs dystrophy, whereas patients who have corneal edema post cataract surgery, DSEC still is the predominant surgery that is done. Interestingly, graft survival at the end of 5 years following endothelial keratoplasty is about 70%, which seems to be quite decent compared to PK, which is about 50% or so from older population literature. So I'll also take a few minutes more, if you don't mind, to actually go through some of the interesting challenges of DMEC versus DSEC at this point of time, and also the decision about whether DMEC is a sexier, better surgery than DSEC at this point of time. Apparently, there are several reasons why DMEC scores over DSEC. One, obviously, the fact that DSEC anatomically is not exactly very natural, whereas DMEC, you can hardly tell apart a patient when DMEC has been done as compared to DSEC. Probably the more important reason is the fact that you have a lesser risk of rejection. In fact, you have an 8-fold reduction in the risk of rejection after DMEC compared to DSEC surgery. And this is the reason why we are trying to do more DMECs post-penetrating keratoplasty failed grafts, albeit with lesser surgical success. But once you do a DMEC post-PK, it seems that these grafts do better than if you do a DSEC in these patients. You also have better visual quality. There's a higher percentage of patients who achieve 20/20 vision after DMEC as compared to DSEC. More predictable IOL power. In fact, we are doing multifocal IOLs. We're doing toric IOLs along with DMEC surgery because the IOL power is only about 0.5 of what you are actually planning from the perspective of implantation. Visual recovery is much faster, and you'll see that this patient with PBK, that is day 1 after DMEC, and in about 3 days or so, the patient actually has pretty good vision in the majority of cases after DMEC surgery. The surgery is uncomplicated. And lastly, refractive predictability is also good because in DSEC, the smallest potential incision you can make for injecting the lenticule is about 4.5 millimeters, whereas in DMEC, you have injectors right now that can deliver the tissue within a 2.2 millimeter incision, thus reducing the amount of astigmatism that you will induce. So the question now is the fact that DMEC is such a good surgery with such great outcomes, and is it the pinnacle of all corneal transplants that the future has to see? There are still a number of patients where DSEC is better than DMEC, where you have more visibility and you have patient comorbidities that do not allow the patient to lie down. But also, what is interesting is when you look at the meta-analysis of comparing DSEC versus DMEC, DMEC scores over DSEC in every study when it comes to visual acuity. But when it comes to endothelial cell density, especially long-term endothelial cell density, DSEC is still better than DMEC. So the potential longevity of a graft is better with DSEC as compared to DMEC. Similarly, rebubbling rates also are better with or lesser with DSEC as compared to DMEC. So what does the future hold for endothelial keratoplasty as a surgical procedure? And do we really need to put in a lot of effort to learn and get better with these surgeries? Potentially not. Some of the earliest results of patients from DSO or DVEC show that this is not a viable option for the future because this only seems to postpone the need for endothelial keratoplasty. It probably cannot replace endothelial keratoplasty. But the real exciting news is from Kinoshita's group, which came out with this paper about 5 years ago in 2018. All of you remember this paper about culture endothelial cells with a ROCK inhibitor. And 2 years ago, they reported the 5-year outcomes of the initial 11 patients who had endothelial cell transplantation following culture in the laboratory. And it seems that 10 out of 12 patients are still doing very well from the initial cohort with sustained improvement in visual acuity, though the morphological features in the endothelium are not exactly very good. In addition to this, there also are some very exciting work that is going on from a Korean group of doctors who also been able to transform fibroblasts into endothelial cells and found moderate success in rabbit eyes. And there also have been novel ROCK inhibitors that are being discovered by several pharmacologists, and also people who are trying to do cell engineering by changing the mitochondria function in patients with fuchs, potentially changing the game for corneal transplantation in the future as well. But probably the most exciting article that at least I have read in the recent past is something that is very similar to SLED. And this is from the Singapore National Licensor Group. Anand, you know this. Jodhbir's group has been doing a lot of good work in reculturing endothelial cells in the laboratory, but they've also found that if you take cells, if you separate them and you inject them inside another recipient without having to culture or expand them in the laboratory, it still has the potential to clear the cornea, and this might be the future of doing corneal transplantation of the endothelium. So to summarize, where endothelial keratoplasty is potentially going to be in about 5 to 7 years' time, PK obviously is going nowhere because we still have so many scars, we have so many infections. DSEC and DMEC eventually will be replaced by cell-based therapy. So don't worry if you are not having very good outcomes with DSEC and DMEC, you'll probably just need to know how to inject in the future. There also is going to be a lot of shift towards cell-based engineering and novel drugs for use. Potentially, eye banks will cease to exist in the way that we know them right now. They will become cell and tissue banks in the future. And eventually, you also are going to have models using ML and AI to predict outcomes of transplantation before you actually do the surgery. So this is what seems to be the future for endothelial keratoplasty, and it seems that we don't have to put in a lot of effort to learn DMEC or DSEC at this point of time. Thank you.
That was very enlightening talk, Dr. Praveen. Next, I would like to invite Dr. Sushmita Shah. She is the director.
And I thank Dr. Somshila and the AIOS for this opportunity. So after the brilliant talk on about endothelium, it's back to corneal trauma, and also thanks to Basha for this title, Do Not Give Up. So I'll describe 3 cases which fit the title of Never to Give Up. So this was a patient who came to us almost 9 to 10 years back. She was 13 years old at that time with a history of Lyme injury, and as you can see, extensive ocular surface burn, including the tarsal and the conjunctiva, and there is a lot of tuna deposits even within the corneal stroma and the stromal haze. So what we did here was we excised the superior cornea, which had the tuna deposits, and put a partial thickness patch graft, and apart from that we covered the entire surface with an amniotic membrane. This is the photograph 8 days post surgery, and this is after about 22 weeks we see a good surface, but there is still symblepharon and the cornea is hazy. Unfortunately, this child was lost to follow-up after this visit, and she presented back after more than 1 year. Her best corrected visual acuity was 6/60, and there was this hazy cornea, limbal stem cell deficiency, and also a large symblepharon involving the superior fornix. So we planned simple limbal epithelial transplantation along with the conjunctival autograft for the superior symblepharon. And this is the photograph 3 days poster. We can see the limbal biopsy tissues in place with amniotic membrane and the bandage contact lens. And she was lost to follow-up after about 3 months of the surgery. And she came back 6 years later. Her best corrected visual acuity was still maintained at 6/60. There was still partial limbal stem cell deficiency, and the symblepharon, the superior symblepharon was persisting. The LSCD was better, but the cornea was still very hazy. So we took her up for a symblepharon release, along with amniotic membrane grafting and the conjunctival autograft and the anterior lamellar keratoplasty. So this is the superior, inferior fornix, which is the symblepharon, which is being released, so that we can put the speculum. This is the superior symblepharon. Here we are excising off the symblepharon from the superior tarsus, and this is fibrin glue being put, and a piece of amniotic membrane which is secured there. Then we put the speculum and go ahead with the surgery. We take conjunctiva from the nasal bulbar conch, which is the only saving conch which was still there. We put it in the bare, over the bare sclera superiorly in the area where the symblepharon was there. Some more conjunctiva is taken for the inferior symblepharon. The bare sclera is now covered with amniotic membrane using the fibrin glue. We trim the amniotic membrane. And now moving on to the anterolamellar keratoplasty, we're trying to push in air, but as it is, it's a patch graft there, so obviously the bubble doesn't happen. So we're just doing a lamellar dissection, and we go to the pre-decimatic level. We didn't try for a full dark, and do a layer by layer dissection. Where the stromas be decimated as much as possible, and we go ahead and put a corneal tissue there. So that's her post-op 6 months. Best corrected visual acuity improved to 618 N6. The surface was also well maintained, and the superior fornix was very well formed. Some residual symblepharon still involving the inferior fornix, and you can see a very good surface on the anterior segment OCT. So my concluding remarks about the case would be that limbal stem cell deficiency and abnormal ocular surface are known sequelae of chemical injuries, and no matter how well you treat the chemical injury in the acute stage, you will still end up with such situations, and they need long-term follow-up and multiple surgical procedures, which can help obtain a good ocular surface and provide acceptable vision to patients. This is my second case. This was a 30-year-old male who was referred with complaints of a white spot in his right eye since 2 months. His unaided visual acuity was 6.6 N6, and on slit lamp examination we could see a white cystic lesion near the 11 o'clock limbus with conjunctival override, and the fluid contained whitish fluid and was noted to be pre-decimatic in location on the anterior segment OCT. Now we went back and looked at his previous photographs, slit lamp photographs. The patient had presented 6 months earlier with a lamellar corneal tear involving the 11 o'clock limbus and an impacted foreign body with some infiltrate within the lips of the wound. The foreign body was removed, and the infection was treated with antibiotics and topical steroids. No suturing was done. So based on these findings, we diagnosed this to be a case of traumatic intercorneal epithelial cyst. The management option, well, patient wanted, even though he was 6'6" unaided, he wanted some treatment because he was worried that it might increase in size, and he was worried about the cosmetic appearance. So we wanted to do something which is minimally invasive. So the simplest could be a simple aspiration, but that leads to recurrence. So we planned an aspiration with chemical cauterization, with the options being ethanol and trichloroacetic acid. So this is a short video. So localized conjunctival peritomy is done to see for any occult scleral tear. The epithelium is debrided, and this is the tear is identified, and the 30 gauge needle is injected, and the cyst contents are aspirated out. Next, we injected 96% ethanol into the cyst cavity, kept it for about 1 minute, and replaced it with distilled water. Now, the single application can lead to recurrence, and if you keep it for a longer duration, it can percolate into the surrounding stroma. So we did multiple applications, just of 1 minute, 3 applications, and then the wound was sutured. And this is the follow-up. We have now about 36 months follow-up. He just has a 0.5 diopter cylinder, but there is no cyst recurrence, and he is 6x6. Quickly, my with your permission, just one last case. So this is a 36-year-old male factory worker who was referred to us with decreased vision and glare, had a past history of corneal tear and repair and iris abscission following an open globe injury. And his uncorrected visual acuity was counting finger at 3 meters, which improved to 6.9 and 6 with a plus 2.5 diopter and minus 8 diopter cylinder. Now he was unaided 6.6 in the other eye, and he vehemently refused to put glasses or even contact lens. So this is the photograph. This is the serious topography, and you can see the localized area of steepening over the area where the corneal tear was. So now what we planned was iridoplasty using the modified citizen knot, followed by PPRK. So the video is from a different case. So we make a side port incision, inject pilocarpine and viscoelastic, and this is the 9-0 proline suture which is being introduced and passed through the either edges of the torn iris and taken out through the cornea. be very careful in phakic eyes so that the body of the swatch of the needle don't touch the anterior capsule. Then the leading edge of the suture is pulled out using a Quiglin hook to make a loop, and suture is made to pass the trailing suture 3 times around the loop. So you do this thrice in a 3-2-1 fashion, and then you suture, then you cut the knot. So next was a TPR case. As I mentioned, he had a refractive error of +2.5 with -8 diopters. So this is the CRS master interface, which corrects only up to 6 diopter cylinders. So we treated the whole the refraction of +2.5 with -6 diopter cylinder. And this is him follow-up 6 weeks. His uncorrected visual acuity was 612 N6. And this is the follow-up. Finally, we have of about 5 months. His uncorrected is 618 N6 with a refraction of -0.75 and -2 cylinder. He improves to 69 N6, and he is finally agreed to wear glasses, and he's happy to wear glasses. So anterior segment reconstruction and visual rehabilitation will still be remain a challenge even after good primary repair, and contact lens as well as laser vision correction may be an effective modality for rehabilitation. Thank you.
Thank you, Sushmita, for that nice talk. Can I ask you a question regarding the? Yeah, I really admire your courage doing that cyst removal with alcohol.
Sorry?
Cyst
Oh,
removal
cyst,
and
okay.
alcohol injection.
Okay, yeah.
So, how do you make sure that it doesn't go into the endothelium?
Yeah, so the thing is, there are publications where people have put for 1 minute, but following you put it for 1 minute, if you wash it out, there are some amount of epithelial cells may still remain. But if you keep it for a longer duration, there is a fear that the alcohol can percolate into the surrounding trauma and cause loss of the keratocyte. So that's what we did. We kept it for 1 minute, and then we replaced it with distilled water. But we again went in, again kept for another 1 minute and replaced it with distilled water. So we did this 3 times, and to make sure that the entire epithelium lining of this cyst is, the epithelial cells get killed without much of it going and percolating into the keratocytes. We just had to.
Okay, that was a good job, but could you consider putting fibrin glue also, like for the the post-LASIK epithelial growth we do, and then just we put the fibrin
Yes.
glue also after moving.
Yeah, post-epithelial growth in post-LASIK.
Post-LASIK.
Yes, post-LASIK, I think I recommend fibrin glue, because there are even lab studies. There is a lab study, excellent study by Professor Dua's group, where they have put in explants and put fibrin glue around it, and they have noticed that the fibrin glue actually stops the migration of the epithelial cells. Now, as we know, this fibrin glue stays for about 15 days, and then it gets it gets absorbed. So as long as the glue is there, it will stop the migration of the the peripheral epithelial cells. So especially in cases of, say, traumatic flap displacement or epithelial growth, in the initial, when you've lifted up the flap, you have done a wash, and there's some amount of flap edema, etc. is bound to be there. So it may not fit very well nicely. So putting glue could be a good option, that in the initial stages it blocks the entry of the epithelial cells while your steroids and everything takes over, and then the edema settles, and I think it's a very good idea.
No, in your case, I was just considering whether we could really do it or not.
In this
yeah,
case?
in your case, yeah.
At the
No,
entry
because see, because suture, the wound should have been sutured in the first episode itself, but that was not done. So taken a chance of putting glue, and if it again the epithelium comes back or something like that, would have been, so the best way was to put suture. So we just put suture. We did not take a chance.
Okay, good job.
Thank you.
Thank you, Sushmita, for not giving up the fight on these challenging cases. With that, I would like to invite Dr. Akida Lal for the talk on pterygium surgery, setting it right. She is the additional.
Thank Dr. Subspecialty and AIOS for giving me this opportunity. After such interesting talks, we are back to a very basic surgery. I'm going to be talking about pterygium today. When we look at pterygium, there are two main goals of surgery. Primarily to achieve a good cosmetic outcome, and the second goal being minimizing the chances of recurrence. Now, the traditional technique of conjunctival autograft was described way back in 1985 by Kenyon et al. And still remains the gold standard for these cases, and it achieves both these goals. Before I talk about the surgery, I would like to go over the parts of a pterygium to really understand the surgery a little bit better. We have the head of the pterygium, which is the part which lies on the cornea. Then we have the body of the pterygium, which lies over the conjunctiva, and the junction between these two is called the neck of the pterygium. The whitish or the yellowish degenerated, conjunctiva that we see here is actually the elastotic degeneration. And understanding this helps us in surgery, because essentially what we are going to do is that excise the head of the pterygium and strip it off from the corneal surface, and then remove all of this degenerated conjunctiva, and then put a conjunctival autograft on the bare sclera that's created. So now I'm going to start with excision of the head of the pterygium, and I'm going to demonstrate this by two different videos here. In the first video here, I am first stripping the head of the pterygium from the corneal surface, and then subsequently excising the neck of the pterygium, and then clearing off the remnant tissue with the help of a number 15 blade. Alternatively, what we can do is we can undermine the neck of the pterygium first, and then free the head of the pterygium, and then use two sharp forces, one for countertraction and one to hold the tissue, and then strip it from the corneal surface. And in both of these cases, we have to clear off the remnant tissue which is remaining on the cornea. This works for most cases, but sometimes we do have these large adherent pterygia with significant amount of corneal scarring, where just simply stripping off the pterygium won't work. And when we are faced with a case like this, we must ask for certain histories. A history of prior pterygium surgery could be a recurrent pterygium, or a prior history of trauma or chemical injury. Here, a crescent knife comes in handy, and we can dissect the scar as well as the pterygium tissue using the crescent knife. And we have to be extremely careful, as the crescent is way sharper than a number 15 blade. We can land up with a multiplanar dissection, or we can end up going deeper than that we intend to. So now that we have talked about excision of the head of the pterygium, I am going to demonstrate a video about how to harvest the graft and how to secure it in place using fibrin glue. So here we are excising the subconjunctival tissue. Again, the appearance of the tissue gives us a clue, and we go in with using a technique of blunt dissection. We go in with our scissors closed, and we open the scissors as we go in, avoiding to buttonhole the overlying conjunctiva, and thus dissect, and then free up the tissue from the underlying sclera and cause the dissection. Then we measure the defect thus created and harvest a conjunctival autograft. Here we could use a subconjunctival lignocaine or BSS as well to determine the plane, and the aim here is to avoid Tennant's capsule in the conjunctival autograft and to harvest a graft as thin as possible. I typically like to oversize the graft by about 10 to 15%. It's easier to trim down the graft if need be. And we do not need to include the limbus for most of the cases. And after trimming down the graft, we are using fibrin glue, using the fibrinogen and thrombin, both the components, in two different 1 ml needles mounted on a 26 gauge needle with a syringe on 1 ml. And then once the graft is secured in place and ironed out well, important tip here is to remove this excess overhanging tissue from the limbus, and this greatly helps in improving the cosmetic outcome for the patient. I'm just going to quickly demonstrate the technique of using sutures for these cases. Here I'm using subconjunctival BSS to harvest the graft. This again gives us a thin graft and helps us in delineating the plane a little bit better. And then we use this interrupted atovitral sutures, taking the episteral bites. If we take the episteral bites, that provides us with better apposition as well as prevents the ballooning up of the graft. So typically we need two sutures on either side of the limbus to secure the graft well. If we have a large graft, we can even place a suture in the middle, and then securing around 3 to 4 sutures, is not more than that, is what we require on the conjunctival side as well. So let's talk about advantages of fibrin blue over sutures. This is a Cochrane review which was conducted, looked at the data including 14 RCTs, and this surgical time on an average was found to be 17 minutes lesser when fibrin blue was used. Surgical time becomes more important when we are dealing with double-headed pterygium or when we are doing a cataract plus combined pterygium surgery. The patient is more comfortable, and there is no level of evidence to suggest that there might be lesser chances of recurrence with fibrin blue. The main disadvantage of using fibrin blue over sutures remains the additional cost of the fibrin blue. There is again a low level of evidence to suggest that there might be a higher complication rate of graft dehiscence in particular. But graft dehiscence depends on a lot of factors, including graft preparation, the manipulation of the graft, the surgical expertise, and eye rubbing by the patient. These were the factors which were found in this Cochrane review. So I'm just going to end with a few tips to avoid these complications. First is to have a meticulous graft preparation, to have a thin autograft to begin with, which sits in better and there is less chances of displacement. To dry the scleral bed before the application of the fibrin glue so that we have a thin layer of glue on top, and then to use the thrombin and fibrinogen components separately, typically onto 1 ml syringes mounted on 26 gauge needles, and iron out the graft well after securing it in place. Equally important is trimming the excess glue from the surface at the end of the surgery, because often it clumps up on the ocular surface, and if we try to pull instead of trimming, we might dislodge the graft. Equally important before we remove the speculum to make sure that there is no glue stuck to the speculum, and educating our patients to avoid eye rubbing post-operatively. Thank you for your kind attention, and before I end, I would like to thank and acknowledge all my mentors who have taught me this surgery. Thank you.
Thank you, Dr. Aikita, for a lovely talk on pterygium. Any questions? Yes, please. Could you come to the mic so that we can hear you better?
Next one.
So my question is, in what cases do you prefer combined cataract?
Yeah, so this is a very important question. There are a couple of factors that we need to look at when we are talking about the question that whether we should do a combined cataract and pterygium surgery in the same sitting, or whether we should take up in 2 different subsequent procedures. First, of course, is what the patient is looking for in terms of visual rehabilitation or pterygium surgery. A very important factor is to look at the astigmatism. When we do biometry and do a pentacam, we need to really look at, do a corneal topography or any device that you have to really look at the effect of pterygium onto the ocular surface, onto the cornea. If there is a significant amount of astigmatism, then it is better to stage the surgeries to take care of the pterygium first, and then go ahead once the surface is stable and you have stable topographies on regular follow-ups, then to go ahead with cataract surgery later on. If the pterygium as such is not inducing a very significant amount of astigmatism, typically flattening in that meridian, then combined surgeries can be planned and we can take care of pterygium as well as cataract in the same sitting.
Thank you. Thank you so much. For the last talk of the day, I would like to invite Dr. Anand Parthasarathy, who will be telling us how to use all our might to manage keratoconus.
For the AIOS and the moderators for the session to allowing me to be a part of this. And I know all of you are reasonably tired, but I must congratulate the last people who are still standing strong. So when I got this topic with all our might, so I decided, let me see if I can give all my might, and I realized that I would need a substitute. So that's the only way I can actually get 8 packs. So no financial interest, but it would be nice to have some. So I guess interventions for irregular corneas or keratoconus is basically broadly into something on the cornea, something in the cornea, something beyond the cornea, smile as in additions. Now, when you look at ectasia treatments, you can look at index, you can look at topoguided BRKs, you combine it with phakic IOLs. There is a very, very good outcome with specialty contact lenses, or of course you can have combination of CXL. But what, as a patient, what are the bugbears for the keratoconus patients? It's about having poor uncorrected visual acuity, or at least having reasonable best corrected vision. They do complain of halos and ghosting, and there is always a small fear of losing vision. I'll start with one of my patients, a software engineer with Oracle. I work in Chennai, so not surprising. Diagnosed to have keratoconus about 15 years back. He's RGP intolerant. He's tried scleral lenses too, but was not comfortable. He's consulted all major eye hospitals in the country, and he presents with these kind of corneas which got very significant central scarring, and that does occur when you're wearing contact lenses 10-20 hours a day for almost about 10 plus years. So very significant central scarring. But he's also done intensive research on keratoconus in me. He's read all my papers published. He knows all the layers of the cornea compared to most postgraduates I know. He also has a discussion on my success rate of achieving the big bubble during surgery. And I did do my surgeries under local anesthesia at that time, and intraoperatively asked me if I'd actually achieved the big bubble or not. Luckily for him and me, the surgery went perfectly, and after about a year, he maintained 6x6 vision, all switches were out, and now he wanted an ICL with this refraction. We did an ICL, but he had also contacted a lot of surgeons because he wanted the one without the PI, which was actually that time not available. He's good, he's 6x6, he maintains vision. And this is about post almost 12 years post DALC ICL implantation, still maintaining good vision, all switches out, and sometimes combining the treatments does give good results. Now, when you're looking at keratoconus treatment, picture on the left and right both have similar management. Just for record, that is not me. You need to stop the progression, you need to stabilize the bulge, you need to improve the contour through intervention, and you need to have measurable results. And this is my paradigm management of how I do it. And broadly, I prefer to do it as structure and function, early and advanced keratoconus. So if you have an early to moderate keratoconus or post-LASIK ectasia, which technically is grade 1 to 3, and if it's progressive, you definitely need to treat it. If patient has reasonably regular astigmatism, has good vision, you can give contact lenses, provided you follow it up with a collagen cross-linking. Both scleral lenses and toric ICLs work very well. You can occasionally combine it with rings, which are the KS or the PMMA rings, and you can do a topo PRK post that, combining it with the collagen cross-linking. If you have irregular astigmatism, like the topography on the right, you probably need to regularize it. So you can do rings, which tends to work well, and then combine it with the topo PRK collagen cross-linking. I feel that is a good option. If you have slightly more advanced keratoconus with no central scarring, you would probably do a collagen cross-linking, gives scleral lenses, works well. You can reduce the irregularity, reduce the cone by using rings, by combining with CXL or even a scleral lens. For slightly advanced cases, if there is stability, ICL works quite well. But if you have central scarring, like the patient I showed you earlier has poor vision, you're probably looking at a down. This is just a couple of pictures of the patient. The top is of the right eye, where we did collagen cross-linking, followed up with an ICL, and the bottom had slightly more advanced keratoconus. So we did intracorneal rings, and then for the residual astigmatism to reduce the sphere and the cylinder, we did the toric ICL. This is just a set of reports for the topo-guided PRK in our center for a 1-year follow-up when you're actually combining topo-guided PRK with the CXL. Gives fairly good stable results, but remember these are for milder cases. But there are some pointers when you're trying to combine collagen cross-linking either with intracorneal rings or toric ICL. Remember, you're trying to combine two different mechanisms of treatment. ICL is a refractive correction, it's a lot more predictable, but it's a one-time treatment. CXL is a biomechanical cellular process, so you have a future which is unpredictable. So in ICL cases, if you're putting ICL in a collagen cross-linking, always aim for at least about a diopter and a half of myopia. Now, Intax is a mechanical, both the KS and the Intax are mechanical effect on an ectatic cornea. So they have different mechanism of action. So you need to understand and then plan it. I prefer the stage procedure, usually about 2 months apart, at least for the CXL and the Intax. Now, I believe it's a revolution in evolution. We started in '99 when I was doing a post-graduation to almost about now where we are actually combining a lot of treatments. Probably my impression is by 2030 we'll probably be treating it with eye drops and probably slit lamp based treatments. Just to go back to that previous patient, he actually got married in 2012. He and his wife sent me a questionnaire regarding the genetics of keratoconus, risk probability transmission of their disease to the offspring, which I frankly did not know. I did read up, but I'm told it's less than about 2%. He's still happily married and has a daughter now, who's about 12. So in conclusion, surgical options for keratoconus corneas using nomogram give good visual results. A combination of treatments, almost all have good successful surgical alternatives with an improvement in the uncorrected and the best corrected vision. And the long-term follow-up does indicate a continued improved effect. Thank you so much.
Thank you, sir. It was a very good presentation, very nice slides.
If you're within about 8.5, at least in Indian cornea, very unlikely you will have recurrence, but it's a thought.
Thank you so much, Dr. Anand. And with this, we come to the end of the Cornea Subspecialty sessions. And I invite all the speakers and panelists to come on the stage for a group photograph.
Let's see.